Good morning, everybody. Welcome to the Lagos State Blood Transfusion Service webinar organized to celebrate the World Blood Donors Day 2020 campaign. The theme for this year's campaign is Save Blood, Save Lives, with the slogan, Give Blood and Make the World a Healthier Place. We have our panelists on board ready to teach us and to educate us on blood and its effects, its relationship to COVID, and relationship to the theme for this year's campaign. We have Professor Akanmu, we have Dr. Dosumun, an associate professor in hematology, and we have Mr. Salu. Please stay tuned, keep in touch. We're starting right now. Keep your questions coming, keep your comments coming, and have fun learning. Thank you.
Once again, we want to welcome you to a special session where we are to learn from those who have been in the field for quite a while. And we all know World Blood Donor Day is very special to us. And today we are going to have a series of seasoned lecturers who are going to teach us from their wealth of experience. And on behalf of the Lagos State Ministry of Health and the Lagos State Blood Transfusion Service, we want to welcome you to this special session. And the first person that's going to have a lecture on this series is Professor Akanmu. Professor Akanmu is a professor of hematology and blood transfusion of the University of Lagos. He is passionate in HIV medicine and also a member of the Harvard PEPFAR program. He was appointed as co-president principal investigator for the Lagos State University Teaching Hospital between 2004 and 2009. He was a member of the National Task Team for HIV/AIDS in Nigeria since 1998 and was appointed chairman of the National Task Team on ART in 2013 and reappointed again in 2016 and is still very active in that sector. He's a trainer and examiner in hematology and blood transfusion, and is an external examiner to many Nigerian universities, both undergraduate and the postgraduate level. He is well published and has had over 90 articles in local and international journals. And also, he is well published, like I've said. He has had presentations all over the world. And today, he's going to speak specifically on transfusion practices, protocols to ensure and giving the lecture and is ready to answer.
Hello.
Hello,
hello.
We can hear you.
Hear me.
Yes.
Thank you very much. Thank you very much. And thanks for the invitation to participate in this webinar to discuss transfusion practices, our protocols that ensure that we are able to keep our donor as well as our recipient safe from the services that we render. I'm projecting what we mean when we say transfusion medicine practice. And there are actually two services that we provide, the donor services as well as the recipient services. We must agree that if there is no donor, there's actually no transfusion practice medicine. Everything in transfusion medicine is about the donor. The donor is the fulcrum of our practice. And we must do everything to ensure that no harm is done to the person who is giving us the product that we want to use to salvage the life of other people. that we refer to as the recipients. A number of activities are done in our practice to ensure again that not only does the recipient get what he needs in terms of blood products to manage his medical condition, but the services that is receiving from us must also be safe. Most importantly, that the recipient must not receive another infections while he's getting our services. Then, of course, we have to understand a number of protocols that we carry out in the blood bank that can cause a problem for our patients if care is not taken. The way we store our cells, the way we store our plasma, and before you know it, you think you are transfusing cell to an individual, whereas you are transfusing live cell or hemoglobin to an individual. These are the things that we must talk about. What is component therapy? What is the role of component therapy in ensuring that we are able to avoid a number of complications of transfusion medicine practice? I would like to share some ideas about this. And then the other areas of transfusion medicine practice that is apparently not very common here now, and I hope tomorrow we'll be doing it, is apheresis, therapeutic apheresis, and also cell collection, plasma collection for donation for transfusion purposes to other people. These are areas that is very, very infantile in our practice. And more infantile are a part of our services that is in support of transplantation medicine, particularly the harvest of a stem cell. These are the areas that appears not to be new elsewhere, but appears to be a new area that we are supposed to be delving into when we have mastered the real heart of transfusion medicine in a way that is safe for our donor, in a way that is safe for our recipient. Now, let us look at Mr. Resource of transfusion medicine practice. Mr. Resource, the most important resource that we have in transfusion medicine practice is that individual that we refer to as the donor. And the donor must receive no harm when we are collecting blood or blood products from this individual. The most important that we must realize that can happen to a particular donor is that you might lay your donor on your donation couch and your donor may not get up because they can go into shock after you have collected blood from him or her. What the physiologists have told us is that when an individual loses about 30% of his or her blood volume acutely, that individual is going to go into hypovolemic shock. And the way we collect blood in the blood bank is actually, it amounts to acute blood loss because you collect between 420 to 450 ml of blood from an individual within a period of 5 to 7 minutes. When your bleeding is very slow, then it takes approximately about 10 minutes for you to collect 420 to 450 ml of blood from an individual. So it's an acute blood loss. So if you collect more than 30% of that individual's blood volume, you might just want to raise up his head after the donation. You find that you have a collapsed patient on your couch. The way to ensure that that does not happen, the protocol says you must take the weight of your donor, and your donor must not be anything less than 50 kilograms. Why? Because we know the blood volume is body weight dependent. For every 1 kilogram of your body weight, you will have 70 ml of blood. If a donor, for example, weighs about 60 kilograms, the total volume of blood that that individual will have will be 60 multiplied by 7, that's about 4,200 ml of blood. If you take 500 ml out of that 4,200 ml, if you express 500 ml as a percentage of 4,200 ml, you get something like about 11.9%. So you are still taking less than 30% of that individual's blood volume. But if that person were to be 50 kilograms, the total volume of blood that he has will be about 3,500 ml. And if you take 500 ml of blood out of that, you will have taken about 14.8% of the individual's blood volume. That person definitely will collapse. So the reason why we say your donor must not be less than 50 kg is that you are looking for an individual that when you have taken about 450 ml of blood from him or her, you have taken just about 12.8 or 12.9% of the blood volume from that individual. And that is the basis of this 50 kg. So you must take the weight of your donor. That if the weight has been taken care of, you must also take care of what we call the oxygen carrying capacity of the blood. So the measure of oxygen carrying capacity of the blood is the individual's hemoglobin level. If, for example, an individual has a hemoglobin level about 15 grams per deciliter of blood, and if that individual happens to have a weight of 70 kilograms, you can calculate the total volume of blood that he has, the total volume of hemoglobin that he has, and the total volume of oxygen that that hemoglobin will carry. And from that arithmetic, you can calculate that the oxygen carrying capacity of the blood, which is defined as the total amount of oxygen that the heart is able to deliver to the body tissues per minute. That is the so-called oxygen carrying capacity of the body. And when the oxygen tension of the blood is about 20 volume percent, that means the hemoglobin is about 15 grams per deciliter. We see oxygen tension at that point in time will be about 20 mils of oxygen in every 100 mils of blood. For that individual that has oxygen carrying capacity of 1,000 mil of oxygen in the whole blood and is delivering 1,000 mil of oxygen to the tissue, your body or our body per minute requires just approximately 250 mil of oxygen from that 1,000 mil. So the body, the blood is able to deliver large excess of oxygen, more than what the body needs to take per minute. If an individual has a hemoglobin level less than 12 grams per deciliter, the amount of oxygen that the body is able to deliver to the tissues per minute might reduce definitely will reduce from 1,000 mil per minute to less than 800 mil per minute. Although the body is able to extract 250 mil of oxygen per minute from 800 mil, but the capacity to do so is always very difficult because the movement of oxygen from the capillary to the tissue is pressure or gradient dependent. With 800 mil, the pressure that is going to drive oxygen to the tissue is much lower than if the oxygen carrying capacity has been 1,000 mil. So you really do not want to get blood from an individual with hemoglobin less than 12 grams per deciliter because the oxygen carrying capacity will be lower, and by the time you take 450 mil of oxygen from that individual, 450 mil of blood from that individual, you will have taken approximately 92 to 100 mil of oxygen from whatever amount of oxygen that individual has. So the oxygen carrying capacity of the blood falls, and it may bring the pressure gradient, what we call oxygen tension of the blood, lower than what it is required to force oxygen from the capillaries into the tissue. So whether it's a male or a female, you must ensure, your protocol must ensure that hemoglobin concentration is more than 12 grams per deciliter. And it is better that you actually do this by hemoglobinometry. Although at the field level, we use our copper sulfate solution, which is fine. But that has been decided that if your hemoglobin is less than 12 grams per deciliter, you will fail that particular test. We call it blood donor fitness test. Taking your hemoglobin either by direct hemoglobinometry or using the copper sulfate solution is what we refer to as blood donor fitness test. So this individual may be more than 50 kilograms. This individual may pass blood donor fitness test. That is not enough for you to say, lie down, let us collect your blood. You must ensure that this individual pass again what we call blood donor safety criteria questions, because he might have normal hemoglobin level, he might look very healthy, but might be hiding some other diseases in his body, and really you do not know. That is very key, that we must ensure that happens. And for us to be able to do that, so you must apply some of these questions to be sure that this individual it is safe for this individual to give you blood. What are these questions? That is what we refer to as donor safety criteria question. And the most important question you must ask, are you well today? Do you feel healthy today? For anybody that feels unwell, please don't collect blood from that individual. If an individual has donated blood or blood product in the previous 2 months, please don't collect blood from that individual, because you are really going to get him to become easily iron depleted. It has been calculated that it is possible for you to donate blood 4 times in a year. That is every 12 weeks. However, the standard regulation, the protocol says, if we must accept you or define you as a regular volunteer returning blood donor, the definition is the individual who is giving blood at least 2 times in 12 months continuously for more than 10 years. That is a regular volunteer blood donor. And you don't have to give blood every 2 weeks. You don't have to give blood every 3 months. A regular volunteer blood donor that is going to have all the merits, because giving blood donation has a lot of medical advantages, but that is today's, it's not the focus for that. There are a lot of medical advantages that accrue to you as a regular volunteer blood donor, but those advantages can accrue to you only and only if you meet the definition of a volunteer returning blood donor. And that means you donate blood every 6 months for more than a period of 10 years. So these are some of the questions that you must apply to this individual, and all the answer must be in the affirmative no, depending on the way the question is interpreted, either full yes or full no. There must be no in between for us to be able to decide that this individual is truly fit to be a donor. Now, having found a fit donor, and that donor, it is safe for him or her to donate, you must also subject our donor to a number of other set of questions that we call blood donor selection criteria questions. These other set of questions are to ensure that this donor, when we collect blood or blood product from him or her, the product we are collecting is safe to our recipient. But the questions is applied to the donor. And a list of these questions is what I'm projecting to you. But 2 or 3 of these questions are actually important. And the first line there that I'm highlighting, have you ever donated or attempted to donate blood using a different name? If the answer is in the affirmative, yes, that is a high-risk donor, and you should never collect that individual's blood. You can read the rest of the other blood donor selection criteria questions. The next slide there will show 2 or 3 other very important questions you must ask. For example, if you say, in the past 12 months, have you given or received money or drugs from anyone to have sex with him or her? And the answer is in affirmative yes. That is a high-risk donor. And you can repeat this same question in different other forms. Have you taken money or drugs for sex? Have you had sex even once with anyone who has taken money for sex or taken stuff like this? Is key and is part of the questions that you must apply, because if any of the answers are yet, these are the type of people who might be actually harboring a number of transmissible infectious agents. So these are what we refer to as blood donor selection criteria questions, which are directed at bringing out finding out whether a particular donor is a high or a low risk donor. Now, let's get to our recipient. What are the protocols that we engage in the blood bank services that ensure safety of our recipient? The most important thing is that we don't want to transfuse contaminated blood to our recipient. That is key. And there are two ways of doing that. We must look for a safe donor. and I will tell you who a safe donor is in the next couple of slides. And then you screen for the so-called TTIs. The WHO recommended TTIs for developing world, not for the developed world. The list of TTIs is quite large, depending on where you are practicing. But for where we are practicing here, we talk about HIV 1 and 2, we talk about HCV, we talk about hepatitis B, and then, of course, syphilis. These are the things that we screen for. We must ensure that whatever blood we are collecting or product we are collecting from our donor, there is what we call donor-recipient compatibility, so that we do not have immunological reactions. Because at the end of the day, immunological reactions can kill our patient or our recipient in a couple of minutes. We have seen an individual who just received a unit of blood at about 2 p.m. and by 6 p.m. he was into the morgue because serology was not properly done, or we didn't pay attention to some important protocol that I'm going to discuss when I focus on serology, particularly the ABO typing serology. That is one that kills our patient if care is not taken. And of course, lastly, we must manage what we call transfusion administration, the records that we keep, the facilities that we use to store our blood and blood products. Because if you don't store those things properly, they get infected, they will get lice, and you are going to be giving our recipient sub-quality products. And that's actually inimical to their health. And lastly, we will see how we manage transfusion reactions using another important protocol, another practice that we are very much familiar with now, what we call blood component therapy. Now, the protocols for prevention of transfusion transmissible infections. Number one, you want to, where it is available and where it is cost affordable, you want to do pre-donation screening, and then you also want to do post-donation screening. But by and large, post-donation screening, pre-donation screening does not replace your looking for a source of safe donor. We can classify our donors into autologous donors and homologous donors. And of the homologous donors, that particular donor that is most safe for us, who is most likely not to harbor any of the TTI, is the one that we refer to as volunteer, financially non-remunerated donor. We say and we claim, and it is true, that is the most safe type of donor because this individual has not been financially induced and not been money induced for him or her to come for a blood donation or product donation. And therefore, he is most likely or she is most likely to answer very correctly all our blood donor criteria safety questions and all our blood donor selection criteria questions. Because many of these other group of donors, they will answer those questions and you will be misled. But the volunteer blood donor will not mislead you. And that is actually the reason why we say the volunteer financially non-remunerated blood donor is the safe donor. But don't let us be deceived that if we got the correct type of donor, that the risk of transmissible diseases will be zero. No, it will not be zero. Not to be zero because, number one, the phenomenon of serologic latency, that is always there. You will see some graph that is showing serologic latency period for HIV, for HCV, and stuff like that. Because of what we refer to as immunosilent infection. Immunosilent infection means some other illnesses that are there, and we really do not screen for them. We don't screen for parvovirus, we don't screen for CMV, we don't for a number of other, and the individual carrying these infections or these viral illnesses are not showing any symptoms at all. We call such illnesses immunosilent. You are not even, malaria will be one of them, but if individual develop malaria after transfusion, when you have malaria parasite and you are not showing any sign of malaria, you collect your blood, and then of course the individual that gets this now develop malaria. That's a form of immunosilencing, and a number of type of infections that our patient, our recipient can still collect from us. So the risk is not zero. You can also have a problem because some of the viruses that you are using antibody to detect their presence, some of these viruses do actually mutate. And the kit that you have is such that it is designed to pick a particular strain of the antigen. And the one that is present in our donor has actually mutated. So when you're looking for it, it is not there. Whereas that particular infectious disease is there. And now we are talking about new emerging viruses. I can hear our executive director telling us that COVID has not been found to be viable in the blood, and then the likelihood that somebody might develop a COVID infection from transfusion is yet to be known. That might be true, but it's an emerging situation, and we have to be on our guard because anything can happen. Because we have now had a report from the Netherlands, we have had a report from Germany, and we have had a report also from China, particularly in Wuhan, detecting or stating IgG, IgM antibodies to COVID-19, but not the variants. So we do not know what is going to happen. We must not lose guard. And lastly, laboratory error. So the accident can still happen. So the protocol must be such that we know our limitations, but we must avoid all sources of laboratory error. This is showing HIV serologic latency, why in fact you cannot say somebody is HIV negative because antibody positive. If I've just been infected in the last 20 days, antibody may not be there. So the virus is there, the antigen is there, but you are looking for antibody to the virus and the patient has not developed it, or the donor has not developed it. That you can be fooled. For HCV, it's even worse because antibody to HCV does not come up until about 70 days after the exposure to HCV, except you are using HCV RNA, which you can use to detect HCV infection as early as 10 days after exposure, but that is not the current protocol for detecting HCV. So when we say our transfusion practice is safe, it's with some limitation. However, if we apply the donor selection criteria very effectively, it helps us to obviate all the deficit, all the defects, that is created from the biology of the viruses and the human beings. Because when the virus enters into our body, we do not develop antibody to it immediately. We wait until a period of time that our immune cells recognize the presence of this antigen. And of course, it takes some time for the immunocyte to divide and mature and becomes a plasma cell that can produce corresponding antibody in the best of individual and in the best of what we call potent immunogens. You wait for at least about 14 days for you to have a detectable antibodies, and antibody level continue to rise with time. So window period, serologic latency period is a problem for us in the blood bank. But having said that, if you look at this data, you will see that the risk that an individual is going to become infected or acquire any of the transmission-transmitted infectious agents from our practice has decreased over the years. In 1983, for example, for every 100 units of blood that you transfuse, one person will get HIV infection, at least one person. And that is the truth. 1 in every 100 person that gets blood at that time will become infected, but not so today, particularly with the advent of the 4th generation ELISA kit and also with the advent of nucleic acid testing for an individual to become HIV infected from the use of blood and blood product. It's about 1 possibility in more than 2.4 million transfusions, unlike 1 possibility in 100 transfusions in 1983. So our practice has become a lot safer because protocol has changed. What has not changed so far, unfortunately, we do not talk about it most of the time, is the risk that an individual will have a bacterial infection from receiving blood and blood product, particularly people that receive platelet, particularly people, yes, because the platelet, we place this back on a rocker that is not usually properly clean, and that blood bags that we say are not impermeable to bacterial agents. So a number of infectious agents do actually percolate through the blood bags, and the platelet product particularly is a major source of bacterial infection that happens in a number of recipients. Not so, the blood is actually kept at a lower temperature at 4 degrees centigrade and supposed to be quickly used. The plasma is usually frozen at minus 80 degrees centigrade, and then the bacteria don't actually multiply. But at the temperature of storage of the platelet, which is between 22 and 25, the bacteria actually multiply, and the surfaces that we place them on are usually also not well disinfected. So that is the problem. So the risk of bacterial infection is 1 in 2,000, whereas the risk of these other viruses getting into our patient is 1 in millions. So, save donor, save blood. I'm just looking into my own data, looking at the prevalence of HIV infection in voluntary donor, comparing it with prevalence of HIV infection in the so-called family replacement donors. The volunteer donor, or the claim that a volunteer donor is 100 times safer than a family replacement donor, that probability of that statement being wrong is actually 0. And we have proven this again and again. And you can see when we do not stick to the protocol of collecting blood from who we refer to as safe donor, we end up collecting blood that is going to be either HCV infected, either HIV infected, or HPV infected, and every month we turn down about 50, sometimes 70 units of blood into the waste and for incineration. And that is because we are allowing people who have not qualified to donate. We are not following protocol to be able to identify a high risk and a low risk donors. Many of our so-called family replacement donors, largely, as experiences have shown us, they are largely touts. They are touts, fronting as members of family who have come to donate for their loved ones. And very unfortunately, all other healthcare providers do make this phenomenon difficult to eradicate. The nurses will always tell you, you will get people who do. They have, even some doctors, they have the opinion that, look, it's not possible for you to eradicate paid donation. I've met a number of doctors, and they have their reasons. Your security staff, the security staff that we have in the teaching hospital and many of the secondary level hospitals, they are touted because they know all the touts and they have returns. These are the issues. The one that is actually most painful is that all these people, they actually work with insiders. So we that provide this service really need to look inward and see what we are doing wrong for money, because we are putting the life of our recipients at risk. So, safe donor is safe blood. And WHO has made this pronouncement long time ago. And to get that safe donor, you should look for volunteer, financially non-remunerated blood donor. And it happens to be the basis for WHO to classify countries of the world into category A countries, category B countries, category C countries. Category A, if between 80 to 90% of the blood that is transfused in your country is from volunteer, financially non-remunerated blood donors. I was in Rwanda and I saw their blood system. I saw how they are using the so-called drones to distribute blood to cottage hospitals. It's fantastic. They are at a different level. The category B countries, the Zambia, Mauritius, and all these people, where 50 to 79% of blood that is transfused in their country is coming from volunteer, financially non-remunerated blood donors. And your category C country, if less than 50% of the blood that is transfused in your country is coming from voluntary, financially non-remunerated blood donor, you can see that Nigeria is not on this list. Likewise, few other countries, Equatorial Guinea, Liberia, Niger, South Lome, they were not on the list of WHO. These countries were not on the list because we are not reporting our transfusion practices to WHO, who were not categorized. The data I presented was published by WHO as far back as 2008. And since that time, many of these countries that were not on the list of WHO have come to the list of WHO now because they've started reporting transfusion data, particularly hemovigilance data to WHO. But in Nigeria, I think we are still planning to do that. We are not there yet. Now, the protocol to ensure that we do not run into immunological complications of blood transfusion. This one is very important because if we don't follow this protocol, our patients die very rapidly. And the most important of all the serology work that we do, the serology work, ABO typing, the cross-match, the type and screen, and antibody identification. The ABO typing is the most significant of all these serology work, particularly the so-called serum typing. When we do cell typing, what they call forward testing, and serum typing, what they call reverse testing. I don't know what they call these forward and reverse. It is better to say red cell typing because you are looking for the ABO antigen on the cell, and serum typing because you are looking for the ABO antibody in the serum. This is what we do not do. We do red cell typing. In most of the blood bank, we forgot the protocol of serum typing. And forgetting the protocol of serum typing is the major killer of a number of our patients. Because ABO typing is unique. Unique in the sense that it is the only blood group system where we have the phenomenon of naturally occurring antibodies to an antigen that an individual lacks. Your blood group A, you lack B antigen, you have anti-B. Your blood group B, you lack A antigen, you have anti-A. So your blood group B means that on this red cell you have B antigen. It also means that in your plasma you have anti-A. So I cannot bring A cell to you. It's a sure recipe. However, you don't just assume that anti-A must be there. So if your blood is blood group B, you expect anti-A must be there. Yes, you must confirm that the anti-A is there. It's important for you to confirm that. It further confirm that individual has B antigen on the red cell. But more importantly is the fact that you are doing serum typing also to describe the property of the anti-A that is present, because that anti-A may be an hemolysin. But if you don't do the serum typing, according to a protocol that is set out, you will miss the property of it. Not only are you going to demonstrate the presence of the anti-A, then you want to say that this anti-A is an hemolysin or not an hemolysin, because we know that particularly in the blood group O donors that have both anti-A and anti-B, 20% of blood group O people have anti-A, anti-B existing as hemolysin. The existing hemolysin, what we mean by that is that if that anti-A or anti-B complexes with corresponding A or B antigen, it will eventually activate complement and there's going to be severe hemolysis. So you cannot afford not to do serum typing. If you decide not to do serum typing, you must never transfuse whole blood. You must know your protocol. Your cross-match is important only and only if you suspect that an individual will have a rare alloantibody. By the time we do a proper ABO typing, I can assure you for compatibility between the donor and the recipient, we are nearly 95% true. Hardly will you have a proper ABO typing and then that blood will now be found to be incompatible when you do the so-called cross-match. And in the so-called cross-match, you will realize that what we do all the time, the protocol that we follow all the time, is what you call the major cross-match. We always forget that there's something that we refer to as the minor cross-match. Because in the major cross-match, what the issue is that you want to put a donor cell in a recipient plasma, and you do not want an antibody in the recipient plasma to rapidly destroy the incoming donor red cell. When you transfuse whole blood or when you transfuse packed cell, remember that that packed cell still has about 30% of its plasma with it, and the incoming donor cell has some antibody that it's carrying with it. So the donor plasma can also be deleterious to the recipient cell. And if you do the cross-match of the recipient cell with the donor plasma, we will say you are doing minor cross-match. The minor cross-match we always forget. And sometimes if you do the minor cross-match, it may help you in avoiding a very serious immunological reactions. The essence of the so-called type and screen is to ensure that our blood is not sent to the world and returned unused. The type and screen method means that when an individual that may require blood transfusion is admitted to the world, particularly those individuals who come in for varieties of surgical interventions. There are some surgeries that will definitely need blood, but there are some surgeries that eventually may not need blood. And we have a list of those surgical interventions. But our surgeons and anesthetists will insist that they must palpate blood. The things we should do, the protocol we should operate to ensure that our blood is not sent and returned is the so-called type and screen, meaning that these individuals, when they get admitted and waiting for the date of their operation, we should screen, we should ABO type them, and then we should screen their plasma for any form of halo antibody. If their plasma has no antibody, and of course you have known, you have done their correct ABO typing. If transfusion, you just go in there and collect ABO identical blood and set it down. So you have not tied down any blood for them until it is obviously or clinically required. That is the essence of the type and screen. For this protocol, not many of us actually implement it. But for us to implement it, it requires a kind of a meeting between ourselves, the provider, and our user, particularly the surgeon. The antibody identification program is very key as part of our serological services to ensure safety of our donor. In particular, if for any reason you are doing a cross-match and you find out that ABO compatible blood during cross-match is incompatible, meaning that a rare alloantibody is there. That alloantibody must be identified. The importance of identifying that antibody is that we will know the antigen that that antibody is directed against. If for any reason we find out that somebody who during cross-match, the blood was found incompatible, donor cell was found incompatible, we collect that recipient serum and we carry out antibody identification procedure on it and find out this individual has anti-big E. The implication is that any donor cell that is going to be given that to that individual, we must ensure that that donor cell lack big E antigen, and that's fine. And that is the way the antibody identification procedure is useful to us, but unfortunately, it appears not to be a very common protocol that we tend to implement in our blood bank. The next series of slides is telling you the method we use to do some of these testing in the lab. Now, if somebody is found to have positive Coombs reaction, so the most important thing that you really want to look out for is this is a recipient that has an halo antibody. I've just discussed with you. You must identify that halo antibody, and then you must know the corresponding antigen, and you ensure that any donor cell that's going to be given to that individual lacks that particular antigen. The type and screen, I think I've discussed earlier, and this antibody identification procedure is a protocol that is very key. We don't need it most of the time, but it's like we have lost the skill of it because we really do not equip ourselves, we do not ensure that our authority, fund us in such a way that we should be able to have what we refer to as panel of cells. What I have in this column are what the so-called panel of cells. You can see this so-called panel 1, the type of antigen that it has, which is positive, the antigen that it lacks, which is 00 there, is known, and you have that cell in your bank. It's a commercially available cell. And then this panel 2, you have it, you know the antigen it has, you know the antigen it does not have. This is panel 3. If anybody during cross-match happens to, the donor cell happens to be incompatible, we bring out the recipient serum, and we bring out this panel of cells, and we react this panel of cells with the recipient serum. And if we like, this is about 6 panels, we react this 6 panels with the recipient serum, and we just see which of the panels is also giving a positive reaction with the recipient serum. If, for example, for any reason, you find out that, let's say, panel 4 and panel 5 are reacting positive with recipient serum, you can see that panel 5 and panel 4 have only 2 antigens in common, and that is P. You can definitely say, oh, that individual has anti-P. So next time that we will require blood, we must ensure that it is P negative blood that he or she receive. Now, the blood administration. You've done all your serology, but it is now left for you to issue blood to the recipients and infuse it into the recipient veins. This is what we call transfusion administration. How have you stored your cells? How have you stored your plasma? How have you stored your platelets? This is key. And if for anything there's a need for us to go back and retract, our step because something went wrong, it is important that we have records to fall back on. And a number of records that you must keep in the blood bank is what I've itemized here. There are a few other records that are not there. Most importantly, this last this record, equipment preventive maintenance register, the maintenance register of your minus 80 degrees centigrade freezer, of your minus 40 degrees centigrade freezer, equipment maintenance register for your blood bank. That is the refrigerator where you keep your blood. And these are the things that we call quality assurance material. All those things must be there because for assessment programs, If you don't have those records, you'll be in trouble. But it is good to keep that record for you to assess yourself and assure yourself that my system is unlikely. No system is foolproof, but it's very unlikely that I will easily falter if I keep all these records. Now, you have collected the blood and you are going to give it out to the ward maid or to the nurse to go and transfuse this individual, what you call blood infusion or blood administration. Certain protocol must be followed. Number one is patient identification, and you must look at the patient hospital case note. What is the patient's name? What's the patient hospital number? So that you don't issue wrong blood. That is very important. Next, you must inspect visual inspection of the blood. If there are micro clots, you can see it. If the blood has slide, the red cell has slide, please don't issue it. These are important protocol that must be observed in blood administration. Then infusion time, you give the blood out to people to go and use, and then in the next 30 minutes, it's just waiting there. They say they are keeping the blood, because the blood is coming from 4 degrees, 2 degrees centigrade freezer, and it's very cold. And you keep it there, and in the next 4 hours, they are still warming your blood. That's a problem. If the blood is not going to be used within 30 minutes, they have come to collect it, and they are not going to use it. If they return within 30 minutes, we can take it back. If they have kept the blood 4 hours in their oven, what they call warmer or something, the blood may have lice, and it's a big problem. So you must always remember that what they call warmer is not correct. It's not correct. If you take the blood out of the fridge, the protocol is that you should infuse the blood like that. The fear we have is that if the blood is at 4 degrees centigrade or maximum 6 degrees centigrade, and you are now infusing a fluid at 4 degrees centigrade to the body whose temperature is at 36, 37 degrees centigrade, the individual might catch cold. That is actually possible, but it is possible only in neonatal transfusion, and that means you must wrap up the baby completely and warm up the baby. But it's also possible only in adult transfusion where you are actually massively transfusing an individual. In that case too, you should put blanket on rather than keeping your blood in the warmer and you lyse the cell in vitro before you even give it. Remember that your infusion giving set, blood infusion giving set, is not the same thing as IV fluid saline giving set. Your infusion set must have filters, and depending on the purpose of the filter, the most important purpose of the filter is to prevent microclot that may have happened in the blood bag. And the microclot will always happen when our people do not follow protocol of just collecting between 420 to 450 ml of blood. What we have in the anticoagulant bag is about 50 ml or 55 ml of citrate, and that citrate has been designed because the anticoagulant blood ratio, as you do it when you want to do coagulation test, is 1:9 volume, and that is the same ratio that you have in the blood bag. So you are supposed to collect 450 ml of blood to 50 ml of anticoagulant that is already put in your anticoagulant bag. When you now put 500 ml, 550, some people will bleed the donor, the bag will be as if it's going to burst. What you have created is a situation where you have inadequate anticoagulation of the blood that has been collected, and you are bound to develop in the bag a lot of microclot, which you didn't see it nakedly. Your filter will help you out. But if you use I guess my time is up because I'm getting some call from somewhere. I'm going to round up. but it is most critical that we infuse the patients with the blood. A certain protocol must be maintained, and that is so-called blood administration procedure. We just, in one sentence, discuss transfusion reaction. I'm not going to go beyond this slide to discuss the rest of the other 10 slides that is behind it, the transfusion reaction. So this transfusion reaction, there is the so-called immunologic and non-immunologic reactions. And it is just the immunologic reaction that I'm going to talk about, and then we close this meeting. The immunologic reactions, there are, I think, 3 or 4 types of it. The immunological reaction against the red cell, which we refer to as hemolytic transfusion reaction. Immunological reaction against the white cell, which we call febrile reaction. Immunological reaction against the platelet, which we called post-transfusion purpura. Immunological reaction against the plasma that we refer to as the allergic transfusion reaction. Hemolytic transfusion reaction with good techniques to our theoretical protocols. To, however, the so-called febrile reaction, the so-called okay, one thing we should also mention that one. So the febrile reactions are only contained if referred to as blood therapy. If somebody high reaction, we know it's a reaction you is going to get must be depleted. And we can have a number, we have a number of filters that I do to remove
Make post. Yes. Yes. You have to make him post. Yes. Ebisa, please continue. No, please continue, sir.
Okay, if you say so. So what I was saying is that the allergic reaction is a reaction to plasma proteins. The most important plasma protein that causes allergic reaction is the IgA. You see, like, and the IgA behaves like red cell antigens. You have anti-A, you have A antigen, you don't develop anti-A, but you develop anti-B. You have B antigen, you don't develop anti-B, but you develop anti-A. Individual who does not have IgA in the plasma, they naturally develop anti-IgA. If you transfuse a donor blood that does not have IgA, so if you have, you have a recipient that lacks IgA, and you are bringing a donor blood that has IgA. If the recipient does not have IgA, he develops anti-IgA. So you are going to have anti-IgA and IgA coming from the plasma of the donor, and you run into what we call immune complex, which can get deposited on the trachea and give severe anaphylactic reaction. This is the thing. And if you identify this type of a person, or this type of an individual, what it means is that this individual must never never receive transfusion that contains plasma protein again. And what you must do, you must prepare washed red cells. And lastly, we talk about TRALI. In TRALI, what is happening here is that the donor has antibody against leukocytes. And that's the issue. He has antibody against leukocyte, and this leukocyte antibody is being transfused to a recipient. And of course, the recipient has corresponding leukocyte antigen on the leukocyte membrane. So you have leukocyte, anti-leukocyte antibody reacting. Unfortunately, when you are going to have leukocyte agglutination, the way you have red cell agglutination, for reasons we are not able to explain, this agglutination decides to occur in the capillaries of the lungs, and you run into serious trouble. What we are supposed to do in this situation is to identify that particular donor who is the source of the antibody, leukocyte antibody, and that individual must never donate blood again and again, because it's going to end up killing the people that are supposed to be taking our services. On that note, I want to thank you for this invitation to participate in the year 2020, World Blood Donors Days lecture, discussing the protocols that ensure safety of our donor and safety of our recipient. Thank you so much. Hello, Komaya.
Thank you very much, sir, for a wonderful presentation. We have a whole lot of questions for you, but we can only take two, sir.
You can defer the questions till other people have presented that don't eat much into their time.
Yes, sir.
Except you feel that it's pertinent that we must answer a particular question right now.
Okay, then we will defer the questions.
Depends.
We will send them to you right now. So after the presentations, we'll answer everything together.
Okay.
Thank you very much once again.
You're welcome.